Thanks for joining us today. My name is Allison Adamson, and I'm an architect at Build Health International. Build Health is a design-build nonprofit that delivers high-quality healthcare infrastructure to the world's most resource-constrained areas, low and middle-income countries like Haiti and Sierra Leone. We specialize in architecture, engineering, construction, and facilities maintenance. Founded in 2010 after the Haiti earthquake, our first project was the design and construction of a university teaching hospital in Haiti. With over 130 team members today, we've completed over 250 projects and worked in over 70 countries worldwide. I've been on the architecture team for almost 9 years now and worked on a variety of projects, from a hospital campus plan in Haiti to a maternity hospital in Sierra Leone to a genomics teaching lab in Nigeria. And joining me here today is architect and board member Jennifer Aliber. Hi, Jennifer.
Good morning. I'm so glad to be with you today.
Can you tell us a little bit about yourself?
Certainly. I've been a practicing architect with Shepley Bulfinch, one of the oldest firms in the country, for 35 years or so. And I specialize in the front-end programming, master planning, and clinical planning of hospitals. And I do mean hospitals, not just healthcare more broadly, but typically hospitals. And probably 80% of my work has been with academic medical centers around the country. Completely the opposite of the work that BHI does. I mean, we're working now, 70 MRIs and the newest proton therapy, that kind of stuff, which is, again, the other end of the spectrum from the BHI work.
Yeah.
Although there's certainly a lot of meeting and overlap in the middle.
There is. So how did you first hear about Build Health?
So I remember who I met Jim and Sarah through. It was a college classmate, and I literally bumped into him on a bridge crossing the channel in Boston, and we were talking, and he's a finance venture capital guy, but his wife's an architect, and he knew I was an architect. And he asked if I knew Jim and Sarah, who had briefly gone to Amherst College. I'm not sure he graduated. I think he got an honorary degree, however, so he has a degree. And I said I didn't. And if I remember correctly, I even accompanied Brian to something that was going on with Jim literally right there. I think I turned around and joined Brian and met Jim, and then I had a follow-up conversation about Jim, about the course of what kind of work was he doing. And I'm not sure, this may have been just before BHI was even founded, and Jim was always trying to think about how does he get architects, particularly volunteer architects, which I think is a fascinating question. So that's how I met Jim initially, but it then went into what work would Shepley be willing, architects at Shepley be willing and able to do with Paul Farmer and Partners in Health.
Okay. And so after many years, what inspired you to be on the board of directors?
Well, I was really pleased with the work that we had done. There was one study that Shepley did, a study meaning the project was never built, for a physical and occupational therapy building, I think in Haiti, but never built. And then we did design the lab building at Mirbelet. Although I had relatively little, I was technically in charge of it, which means if something went really wrong, it was my fault. But I really didn't have much to do with it. But the two architects who did do the work ended up leaving Shepley to join BHI.
Right. So you clearly have many decades of experience in healthcare architecture. What are some of the most pressing challenges in designing healthcare infrastructure?
So I tend to divide infrastructure into two categories. There's all the things necessary for a building to get built, particularly energy and other resources, as the civil engineering, all the engineering stuff. And then there's the architecture itself. And frankly, the most pressing issue, regardless of probably whether it's in Malawi or Haiti or LA or New York City or anywhere, are the capital resources available to do the appropriate project.
Okay.
And nothing changed. I mean, one project may be 100 or 100,000 times more expensive than the other, but if the money's not there, the money's not there.
Right, right.
So there's that part of it. It's just really hard.
Mm-hmm.
Architecture's a difficult business.
Definitely.
And then we have the issues of codes, needs, how is healthcare delivery going to change
Yep.
in the future, and how do we design for it? I think it's fascinating that when our clients, and again, I mean academic medical centers or hospitals, hire a strategic consultant to tell them what they need, those consultants will give them a 3-year time frame.
Okay.
They don't want to talk about what happens in year 5, year 10, year 15. Well, most of the projects I work on take at least 7 years to get built.
Right.
So we're more than double the confidence level of the strategic consultants. And it involves a lot, as I said, a lot of money to build these projects. Right. So how do we make sure the projects are built to last?
Right.
I'm not convinced we need 100-year projects. I have a colleague who worked at Stanford, and he kept talking about the new Stanford Hospital being a 100-year project, and I kept thinking, I don't think you want a 100-year project. I think you want a way to do part of a 100-year building, but at 25 years, 50 years, 75 years, it's been designed to adapt and change.
Okay. As the codes change.
As the codes change and the technology. Again, the work I do is often so technology-driven, but it's hard to know exactly where and when, and sometimes code-driven.
Right.
So, the factor that has changed the look and size of hospitals the most was a regulatory issue that said that all new hospital beds in the U.S. would be single-patient rooms.
Wow.
So suddenly, any new, almost doubling, not quite, but 160% larger.
Yeah.
Just because the code changed.
Wow. And speaking of codes, you're currently working on a technical review of the Rwanda Healthcare Facility Guidelines. Can you describe what these guidelines are and what they're aiming to do for the country?
Well, you're really the architect and project manager in charge of that. To me, guidelines and templates are a really interesting issue, and I'm going to divide it into 2 parts. So the first, and I can understand why a country wants guidelines. A country with, what I'm going to say, emerging healthcare infrastructure, making sure that they build things, the right kind of things, but also replicable from site to site to site. And this is the same true for healthcare systems in the U.S. Who wants to run 20 hospitals under a healthcare system and have them all look and operate completely differently? So guidelines and templates make a ton of sense. Once you're building more than 2 or 3, they might as well be similar. You can move staff back and forth. The expectations of patients are set. I mean, I don't really want to equate McDonald's and healthcare, but that said, one of the reasons people like McDonald's is regardless of what part of the U.S. you're in, how I order and what I can order from the menu and what I actually get is the same.
Yeah.
So when I go to an OR or an exam treatment room, shouldn't those be similar from place to place to place, at least within a system? So that's one of the benefits of templates and guidelines. Also, it's cheaper, right?
Yeah,
you don't have to redesign every darn thing. You can order more of things in bulk. I mean, lots and lots of reasons to do it.
Yeah, and you brought up, you know what you get, so I imagine there's a level of comfortability for administrators, staff, and also patients.
Absolutely, absolutely. I can remember 10 years ago, almost 10 years ago, we were designing a significant addition, not quite a full replacement, but significant addition for a hospital in Tucson. And that same system had just built much the same kind of project in Phoenix. And we just took the surgeons up to Phoenix and said, will these ORs work for you? And they walk in and they looked around. And they said, yep, we were done.
Cool. Yeah.
So much easier.
Yeah, definitely.
Much easier. But the downside of guidelines and templates, it's great in the now. But what happens when there's an innovation?
Right.
I mean, does a template allow, how do templates and guidelines allow for innovation when we don't really know what's coming in technology and care?
Yeah.
We may think we know. So there's this uncomfortable balance between standardization and innovation. I don't have any good answers for it other than to say it's the tension that exists.
Right.
And I will say most of the owners I've worked with who have templates and guidelines, they're neither as comprehensive, complete, or useful as owners may think they are.
Yeah.
The situations are just a little different.
Yeah.
I think when I think of how do you deal with the issue of guidelines for a country like Rwanda, low resource, there's another wrinkle, which is what is the appropriate investment in infrastructure.
Yep. We're very aware that they're not standards, they're guidelines, and there's options for multi-bed wards and options for single patient bedrooms and options for hybrid ORs and more general smaller ORs too.
Right. So I think that's exactly so. When BHI is doing the Rwanda guidelines, I think that so they have the guideline tension and complexity, and then they have and what's the appropriate level for these, for Haiti, Sierra Leone, Rwanda.
Yeah.
And there's no perfect answer. It's a judgment call.
Definitely.
Almost on every single issue.
Yeah.
Although I will say, if you think at some point in the future that, there's a set of 6 ORs for Rwanda, but 15 years from now there may be 12 or 10, and those new ones might be bigger and need more, then from a planning perspective you can begin to think about that. And I think that's part of BHI's responsibility. You don't have to build it today.
Right.
But you should know that it's coming in the future.
Yeah, and we're trying to be careful with our language of stating these are minimum to provide the minimum amount of high quality care, and then you can build up and expand as technology expands too.
And that issue of minimum has been an issue in the U.S. with the facility guidelines, which are the minimum.
Right.
But there's one set, and that's everything from a small rural hospital to a 1,500 bed academic medical center. That's a big gap in need, process, delivery, but there's one guideline.
Right.
And that's a tough. That is a really big spectrum of care to expect a single guideline to accommodate.
Yeah, and that's what we're struggling with too, because Rwanda's laid out, their level of facilities from a small health post up into, a national teaching hospital. So how do we've divided by unit, but then within that we're trying to state, what's the minimum for lower level hospitals versus higher level. Yeah.
Right. And then in the U.S., the other issue is, as we think about learners, medical students, nursing students, pharmacy students, all those folks. I mean, people tend to think of doctors and nurses, but care teams are much, much larger, and they all need to be trained and taught. And that training much of it is on site with patients. So an exam room may be an exam room, but suddenly if there are 4 extra people in there, it almost doesn't matter if it's at a small rural facility or a big one. That exam room now needs to accommodate the patient, maybe 2 family members, and now 6 clinicians of various kinds. So that's another wrinkle. I certainly wouldn't recommend that every exam room be built to that.
Yep.
But what accommodations are going to be made for learners?
Yeah, and that's also ties back to talking to the stakeholder and figuring out what each specific location needs. We'll make the template, but then it can be revised from there based on how many family members typically accommodate you, what types of health issues is this community happening.
Right. So the academic is just another wrinkle, and at least in the U.S., and I would expect eventually in Rwanda and everywhere, the learners will eventually be everywhere. Not all the time. They'll be far more in the true academic center. Yeah. But at some, the learners will show up in smaller places.
So there's been a level of mentorship with the health facility guidelines, the small team at BHI of architects writing these, and Shepley has put together a team to have weekly meetings with us discussing the nuances of an ED and a surgical suite, and you guys have provided comments to us. Can you talk a little bit about that exchange between BHI and Shepley? And I know I've personally benefited a lot from it, but you've alluded that Shepley's also learned a lot too.
So the Shepley has about 180 employees. They're not all architects, but most are. So let's say there are 150 architects around the country. We put out is there anyone interested in reviewing these guidelines for Build Health International for a project for the Rwandan government? And I think we had a group of 8 or 9 people said they're very interested. But it's a range. One of my colleagues is a principal like me, and the others are at different levels in their career. And the meetings have been really interesting because I think our emerging professionals, those with less experience, are learning more probably than BHI is. That may not help BHI very much, but it's helping Shepley. And then I think some of the more experienced architects are probably helping you with more substantive questions. There may not be answers, but questions you BHI can be thinking about.
Yeah, things to think about, and even, we're specifically working on the emergency department now and realizing how complex it is and how many ways there are to organize it, so it's helpful to hear how others have been approaching an ED design.
Yep, and ED designs are fascinating because again, how large, in some cases size is a really big issue.
Yep.
And in terms of the models of design, and in other cases they're not. Although I tend to believe scale and size should always be important to architects, and I'm sort of stunned at how infrequently they think that way.
Yeah. Yeah, because the size of it depends how much support space you need and where that gets situated.
Well, also some models of care work for a group of 8 that don't work for a group of 16.
Yeah. So
maybe you need 2 groups of 8 and figure out how to connect them. But just adding more doesn't always help.
So coming from the high-tech background working on projects in the U.S., how have you or the Shepley team reoriented your mindset when determining the considerations and advice you're giving us working in Rwanda?
Well, one nice thing about our experience at Shepley is many of our clients we've worked with, I've had the same client, not always the same people, although some of them have been around for the same 30 years. So we tend to, over time, have an idea of what works within one institution and what doesn't. So we can say, well, we tried this, and the owner really liked it in years 1, 2, and 3, but over time, it didn't work, or they found it wasn't flexible. So that's, I think, one of the insights or types of insight that we can provide. I will find one of the, and I'm sure all the architects at BHI know this, but the battle of how big should a room be is that's an annual, actually it's a daily, and you try to help an owner understand, is it worth investing a little more now so that you don't have to come in and fix it later. And many of these things you can't really fix later. You have to do you really have to do a full-blown demolition. Well, if you've only got 12 ORs and demolition, and they're all 85% of the size they need to be, at some point they're useless.
And that was one of the many things I found helpful from these conversations is while we're struggling with, how to size a room, it's a little comforting to know that it's not unique to us in our projects. A lot of people struggle with that too, no matter what project
Everyone struggles. Everyone struggles with that because it's a really hard question. In some places in some parts of healthcare, it really matters a lot. I have one client who has the great majority, I'd say 60-75% of their med-surg beds are in single patient rooms, but they are 135 square feet. Wow. That's tiny. That's probably smaller than the average room size of what an American girl has in the suburbs of Charlotte, North Carolina. And that child presumably is not sick. So those bedrooms have been around 50 years now. Would cost billions to replace those 664 rooms. So every year, They don't get smaller. They just feel smaller as
Yep.
the years go by.
Yeah, and more equipment is
And more
coming
equipment.
too.
Because
Yeah.
we do things in patient room. I don't, but clinicians do things in
Yeah.
patient rooms that they never used to do.
Right. Right. Yep. So I know BHI works in very specific settings, but there's health disparities all over the world, all over the country. Do you know of other architecture firms that are trying to address this?
Well, it's an interesting trying to address the
Health disparities.
disparities.
Yeah.
I think almost any firm would love to do it, but it's
Yeah.
always, again, finding what is the right template or guideline. What is the right set of architectural planning?
Yeah, because it's hard to do successfully.
And hard to do, and how might things change in the future? One thing I don't think many people really saw coming 20 years ago was this idea. 25 years ago, the great majority of hospitals were independent. There's a hospital here and another hospital here, and then we sort of moved to systems thinking or system acquisitions, and suddenly you had the big academic medical center and then a bunch of regional hospitals and then community hospitals and then maybe some urgent care and ambulatory sites. So suddenly you have this constellation of healthcare delivery sites within the same system. So what should be the difference? I'm working with an owner now, and they call it, the site we're working on, they call it one of their tertiary hospitals. It's less than 300 beds. I would call it a community hospital plus. So the question is not what services should be provided here, but also how much might change in the future. How many learners will ever be on this site? It's never going to be an academic medical center, but that doesn't mean there won't be learners. But the disparity issue is a really tricky one. What are these? What are the expectations of patients? What are the expectations of clinicians? How can the community support it? We've had an interesting problem. I've had several owners who have approved projects. Occasionally they've even been built, and the CEO comes in and looks around and goes, "This looks like it costs too much. Start over. Rip it out and start over." Because it sends, if your uncle was just laid off, and many other people in his community were laid off, the big company town, the company that town was built on goes out of business.
Interesting.
Suddenly, you don't want the fanciest building in that town to be the hospital. It sends absolutely the wrong message.
Interesting.
So
goes back to knowing your location and your stakeholders.
And what's appropriate. We always have this issue about lobbies, which personally I could do without because they're not interesting to me. But we usually have somebody on an owner team who says, "I want a wow lobby." And go, "Well, what do you want that lobby to say?" "Oh, I just want it to be wow." And then it's like, well, if I'm already struggling with health insurance, you really want me to think that this is where my money's going?
Right.
And often that person who wanted the wow thinks, "Oh, maybe not. Maybe I'm just shooting ourselves or myself in the foot."
I think you really have to know the building users, because if it's not comfortable, if it doesn't, if I don't want to go to this hospital because of how it looks or how the rooms are set up, then that's not successful. The same thought needs to be had from beginning of the project throughout.
Right. If it doesn't feel like a place for me as a patient, I am not going to go.
Right. So important in everyone's work.
Right. And it may not be just about can I afford to go. It may literally not be a place that looks like
I belong at.
I belong.
So interesting. So outside of the Rwanda Healthcare Facility Guidelines, are there any other developments at BHI you're particularly excited about?
Well, I think just so BHI is trying to do so many different things. Shepley is just an architecture firm. It's all we do, architecture and interiors, but it's basically architecture. But BHI is really the architecture, the engineering, the construction, the ongoing operations and maintenance. So all across the world. That is a completely different set of challenges that I think are absolutely fascinating. My insight is only really on the professional services part of the architecture, maybe a little on the engineering. My view is that's a hard enough business alone. And how does it also become, I don't want to say standardized, but efficient and effective?
Right, yeah.
And how do you all learn? A project in Malawi, and Haiti. On the one hand, probably similar, but on the other, a whole bunch of little but important distinctions.
Yeah.
So how does the design team understand those?
Right.
One thing I really love about the BHI approach is I think it's really rooted in understanding, in my view of infrastructure, the engineering. There's no point in building an American-style hospital in a country that can't support it.
Yep.
That doesn't have the electricity or the power or whatever else to support it. So how does... Anyway, so I love that approach. The BHI's first approach is not going to design anything that can't be sustainable. It's just dumb. And I must admit, when I look through the fancy architecture design magazines, and every couple of months there's some project somewhere in Africa, and it's some firm from New York City, and you're like, yeah, that thing looks good on the opening day, and half the equipment will never work.
Right, yeah. That's part of the resiliency of it, too. If you can't put something there that's going to break in a week or month, because then it'll take a year to get fixed, and then it's useless for that year.
So one of your colleagues, Gerard Georges, and I went with a group from Mass General to look at the possibility of doing a cancer center in Uganda, 5 hours from the capital.
Wow.
And they wanted a full-blown cancer program. We started out in the capital. There is a cancer center there. But their one and only linear accelerator was down and had been down for 2.5 years. Wow. It was then a brand new building.
Yeah.
But it was broken, never replaced, and I think it's still broken. So if that's, I don't want to say the best, but if that's the situation in the capital, why are we even talking about radiation therapy 5 hours away?
Yeah.
So figuring out what's realistic in both a near-term time frame, but also a further one.
Yeah.
And I think then, again, the Partners in Health and BHI approach to saying the vast majority of people in any country, including the U.S., probably benefit more from preventive care and public health measures more than radiation therapy. Not that we want anyone to die of cancer if there's a treatment available out there, but in terms of number of people and quality of life, it's still the easy things, right?
Yep.
Clean water, sanitation, vaccination, seeing a healthcare person, community health.
Yep, that all is a part of healthcare infrastructure.
Right.
It all ties together.
It's not the part I'm interested in from a design perspective, because that stuff doesn't result in hospitals, but really that's where the value begins.
Right, and it's fixing, to fix that machine, it's fixing the electricity and the biomed equipment before we go building a new hospital. So understanding the community restraints, really getting to know the country, the local context, and the local healthcare systems. Yep. So my last question for you is, how can the local community here in Boston, local organizations, what can we do here to enable low and middle income countries?
So this gets back to my first introduction to Jim and Sarah, which was how can American firms, so I'll take it in the narrow way, right? How can architectural firms and architects be helpful and participate? And what was driving Jim nuts, I think probably just before he founded BHI, was people would volunteer, but they couldn't volunteer indefinitely. And so he'd get chunks of people's time or firms' time, but then they would leave. So he was always juggling, who's really going to work on this? How can I count on them? How do I factor in, okay, so I'm not paying salary, but I'm spending a lot of time figuring out who is doing what, and is it what we need? So I do think the issue of how do people participate is an interesting one. One of the things Regan Marsh, the emergency care physician also on the board, had done, BHI had done through the Boston Society of Architects, a couple of, and you may have participated in one or two of these, but especially during the Ebola crisis would almost say, here's a little problem, how can we all brainstorm and think about solving it?
Yeah.
So there are ways to, I think, reach out to the larger community that are also learning opportunities, because we may have someone on Shepley, or firms like Shepley, have someone on staff who's sort of interested in healthcare design, but doesn't yet know much about it. One of the things I think is really helpful about the BHI kinds of projects is some of them are kind of elemental. So in terms of infection prevention and Ebola, those lessons about donning and doffing, all of that predated COVID, but people who had thought about it with those sessions with BHI and Dr. Marsh benefited when we started thinking about, for our local community hospitals and COVID. So they're those really elemental and foundational issues. I hope BHI continues to think about ways to invite others in for brainstorming. Just the way I appreciate that Shepley was invited in. Again, I'm not sure how helpful we'll be to BHI, but I know the folks on the Shepley side listening have benefited.
No, and I keep saying how much I learned from those conversations, and just how I much enjoyed talking about all the nuances of these very specific healthcare units. And I hope maybe we could continue either for the guidelines or for other projects, if it's sending a floor plan and say, hey, what's not working well for an infectious control? How can we shift some rooms around to improve flow?
Allison, I think that's a great idea. I think it could be enlarged to a group. Maybe Boston-based firms, just because occasionally it'd be nice to do stuff in person, but not necessarily. But the folks in healthcare design who are planners, which is what I do, love reviewing and talking about plans. So there's a built-in group there, and they're easy to find. So maybe a task for 2026, 27 is for BHI to broaden that.
Start planning that. Well, thank you so much for your time. I really enjoyed our conversation. Appreciate talking to you. Thank you so much for listening. We look forward to sharing more of Build Health's stories with you all.